Good morning, everyone from Brazil. Welcome to our 12th IACAPAP Lunch and Learn webinar. Today, we will have a very special symposium dedicated to Joe Biederman. As most of you might know, Joe was a leading force in child and adolescent mental health, either in research and in clinical work, especially in the area of child-adolescent psychopharmacology, and more specifically in the area of ADHD. He was the mentor of several child and adolescent mental health professionals, including myself, and he was key for the development of all the research and clinical work that we did in Brazil in ADHD, as well as a mentor for the two colleagues that I have the honor to have with me in this symposium. I'd like to introduce you first, just a second. Sorry. First, I'd like to introduce you the chairperson of this symposium, Professor Steve Faraon, who is a distinguished professor and vice chair for research at the Department of Psychiatry, Norton College of Medicine at SUNY Upstate Medical University, New York, United States. And you all know Steve is a leading force in different areas, including ADHD. He is the president of the World Federation of ADHD. And whenever you go to the website, to the Web of Science, you will see that Steve is the most productive researcher in ADHD, followed by Joe Biederman. And it's my pleasure to introduce Professor Iris Manor, who is a senior psychiatrist of children and adolescents, director of ADHD clinic at the Dan Petashtipak Mental Health Clinic, associate professor at the Sackler School of Medicine, Tel Aviv University, Israel, board member of the Israeli Society of ADHD, and board member of the American Professional Society of ADHD and Related Sciences. And as you all know, one of the leading forces in child and adolescent mental health in Israel and worldwide. So I will ask Steve to continue the session.
Thank you, Luis, and thank you for organizing this symposium to honor Joe Biederman. Joe was a very close colleague and friend of mine for over 40 years. Let me tell you a little bit about his life. Joe was born in Prague, Czechoslovakia, at a time when the Nazi plague was horrifying Europe. He would lose most of his extended family to this, to World War II and what ensued, but his family escaped thanks to the beneficence of Oskar Schindler, and they emigrated to Argentina, where eventually Joe would go to medical school at the age of 23. He would attend medical school in Buenos Aires, and eventually go to Jerusalem to complete a residency. And his residency in Jerusalem was a key point in his life, because up until that point, all he had learned in psychiatry about children was psychoanalysis. And he was, believe it or not, Joe Biederman, currently known as the father of pediatric psychopharmacology, was training as a psychoanalyst. And he met Robert Bellmaker in Israel, and this man changed his life. He saw how Bellmaker was studying lithium, how lithium was transforming the lives of patients with mania. And Joe himself was transformed. He became a clinical researcher, and he delved into child and adolescent psychiatry and completely changed his direction, where he would eventually go to Boston and develop a pediatric psychopharmacology clinic. As Luis mentioned, Joe has been incredibly productive in his career. This is a graphic here which shows you over the years co-publications between him and myself, 503 results from PubMed of papers that Joe and I authored together. And I can tell you from personal experience, He was an amazing person in his ability to conceptualize papers, to write manuscripts. I've never known anyone to write a manuscript as quickly and as effectively as Joe could do. And as a result, he has these sky-high publication metrics. I mean, his papers have been cited over 50,000 times. He has an H-index of 121, which is an amazing publication metric in any field. In 2014, Thomson Reuters included him on their list of what they call the world's most influential scientific minds across all disciplines. Another ratings group, Clarivate Analytics, has always listed Joe in an elite group of highly cited researchers each year since 2014. And publication metrics are one thing, they don't cover everything, but it's also important to note that Joe has been awarded many honors from a variety of organizations. And this is not a complete list. I'm not going to read this list to you, but I'll just mention that he's had awards not only from his local hospital, Mass General, from the American Academy of Child and Adolescent Psychiatry, the American Psychiatric Association, CHAD, which is a family support group for ADHD in the United States. He won the highest award from the World Federation of ADHD and from the American Professional Society of ADHD and related disorders. And U.S. News and World Report has listed him among the top 1% of psychiatrists in the USA on a regular basis. This is a key point. Joe was not just a researcher. He could do both things well. He carried a large caseload of patients, and he also conducted research. Very unusual researcher in that regard. His contributions to child and adolescent psychiatry, many, they go beyond ADHD. He discovered many of the psychiatric comorbidities of ADHD that we take for granted today. He was the first, or one of the first, to systematically study and validate and treat ADHD in adults. This was back in the 1990s when only Paul Wender in Utah and Joe Biederman in Massachusetts were doing this. Proposed a neurogenergic theory of ADHD and atomoxetine as a treatment for ADHD. That's a long story, but atomoxetine would probably not be here as a treatment without the work of Joe and his colleague Tom Spencer at the Mass General. I don't have time to go into all the details of all these developments that he did, but it's unbelievable all the areas of research in child and adolescent psychiatry and adult ADHD to which Joe had made important contributions. And part of those important contributions was a list of very high quality clinical researchers. These are people, and this is a short list of people who I would say he influenced most strongly, most of whom were trained at the Mass General Hospital. Also, I met Professor Roger is here because, as he mentioned, he himself was strongly influenced by Joe, and the wonderful work he's doing in Porto Alegre in his clinic is in many respects attributable to Joe. Not to take anything away from Luis, but Joe had a very strong influence on that clinical research program. And I'll just say that, if there's one thing we can do in this world, we can leave it a better place than it was when we first got here. And Joe can certainly say that the world is a much better place because he was here, both as a clinician, as a researcher, and as a human being. Most people didn't know Joe personally, but he was a wonderful, kind person who was always willing to drop everything to help a friend or a colleague in need. And so as we celebrate Joe today in this memorial service, we should keep in mind these wonderful facts about his life. Now I'll turn it over to Professor Iris Manor, who's going to give today's lecture.
Okay, thank you, Steve. Thank you, Steve. Like always, I'm a bit excited when we talk about Joe. He was a great researcher. He was a great person. He was a great friend. I think he was a genius, born one in 100 years. And he was really a very good friend, as you said before. This is the last study, the last paper that we wrote together, and we began a new study. Unfortunately, we had to finish it without him. So this is for his memorial. And I'll go now to science before I'll begin crying. So this is going to be about ADHD and its association with increased rates of childhood infectious disorders, a population-based case control studies. Why doesn't it work? Here's my disclosure. Infectious diseases pose a heavy burden in children, accounting for approximately 25% of pediatric hospital admissions. Therefore, a key goal of prevention is to identify vulnerable pediatric populations. And one such potential risk, although neglected for IDs, is ADHD. An association between pediatric ADHD and infectious diseases has been previously documented several times before COVID, including upper and lower respiratory tract infections and influenza, and also childhood shigellosis. Population cohort study recently showed that ADHD children treated with stimulants had a reduced risk of being infected with upper and lower tract respiratory infections, influenza, and childhood shigellosis during the treatment period. With stimulants, of course, with ADHD medications. All that was before COVID. During the recent COVID pandemic, ADHD children were at higher risk for infection. Children treated for ADHD were less vulnerable to be infected by COVID. Adults treated for ADHD were less vulnerable for complications of COVID. Adults also exhibited a lesser infection severity. Children and adults actually exhibited a lesser infection severity. They were significantly less symptomatic. They were significantly less hospitalized, had significantly lower 30-day mortality, and they were less likely to utilize emergency department hospital and ICS. Our hypothesis was that pediatric ADHD may be associated with an increased vulnerability for infectious diseases in general. Since ADHD is a highly prevalent disorder worldwide, a vulnerability to infectious diseases represents a significant public health concern. Such a vulnerability is critical in a pandemic such as the one posed by COVID-19. Still, nobody talked about it before COVID. Our study was a population-based case control study of ADHD diagnosed children in an Israeli health maintenance organization, Leumit Health Services, serving approximately 750,000 persons during the study period. And it was a comprehensive computerized database. The prescription records were available from 1998, including those refilled and purchased per patient. The diagnoses were according to the International Classification of Diseases 9 or 10, depending on the year. Ongoing diagnosis affirmation process is very common in Leumit, so clinicians are encouraged to report to the medical division experts about patients that they believe do not meet the criteria for a particular diagnosis anymore, and then this diagnosis is removed. Thus, the validity of such diagnosis in the registry has been previously examined and confirmed as high. The study design is shown in figure 1. As you can see, 750,000 members. We took only children, around 200,000 of children, and from them we took a case group of 18,756 children diagnosed with ADHD, and they were matched in a 1-to-2 rate on age, gender, and ethnicity and SES. And we had a control group of 37,512 children who answered the criteria and were part of the control group. So we had children, all in all, 56,000 and some children aged 5 to 8 years. The mean age was 8.3 years from January 2006 to 30 June 2021. We excluded, of course, subjects who were aged less than 5 or more than 18 years, subjects who had an underlying oncological disorders, or subjects who had a primary or secondary immune deficiency. All the demographic variables were very similar between the groups, with no statistical differences, implicating a very successful matching. The ADHD children were children with an established diagnosis of ADHD. The diagnosis was made according to the international evaluation requirements by a diagnosing physician who had to be a senior physician specializing in the ADHD field. The diagnosis was established according to DSM-4 or 5, again, it depends on the year, and the matching ratio, as I said, 2 to 1, by age at ADHD diagnosis, gender, SES, and also by BMI. Control group was randomly selected from the study population. By the way, the socioeconomic status in Israel is defined according to the child's home address using the Israeli Central Bureau of Statistics classification of 20 subgroups. So it's a bit different between countries. None of the children was diagnosed with ADHD before the reference date, the date of matched cases ADHD diagnosis. So this is table 1, the table of the social demographic characteristics. And as you can see, there is no difference between the groups, between the ADHD and the controls in all the factors that I talked about before, including BMI. We used 3 exposure criteria or categories. The first one, the pediatric infectious diseases themselves. They were ICD-9 coded, including the 5 years before the reference date. And we looked for 2 things. We looked for the type of the infection, and we also looked for the body system involved. So we looked for 2 things, not only for 1. The second thing was anti-infective medications according to the ATC codes. And the third exposure criteria was physician's visits, as were recorded during the 5 years before the reference date. These physicians were primary physicians and specialists. The statistical analysis was performed using the R statistics software. Assumptions were 2-sided with an alpha of less than 0.05. Social demographic characteristics between the study and control groups were compared using t-test and Fisher exact chi-square test for continuous and categorical variables, respectively, based on the normal distribution and variable characteristics. The rate of pediatric infectious diseases the rate of pediatric infections, the use of anti-infective medications, and the visits among different physicians were compared using logistic regression analysis, and odds ratio and 95% confidence interval were calculated. The study protocol was approved by the Ethics Committee Review Board of Shamir Medical Center and the Research Committee of Leumit Health Services. So what happened with the diagnosis? The rates of other infections were significantly higher in children with ADHD than in the matched control group, and the increased infection rates were not restricted to a single body system. We saw these differences, these highly statistical differences in many body systems. The most common childhood infections were included. They were acute respiratory infection and acute gastroenteritis. And also, very important, infections of all 4 major groups of causative microorganisms were significantly more common in children with ADHD. I will skip for a moment. You can see in the tables, these are the bacteria, these are the viruses, these are the funguses, and the parasitics, and the parasites. And this increase was considerably high, especially in specific infections. For example, salmonellosis showed the highest OR of 2.8. So again, as you can see, all the values were really very, very impressive. What about the anti-infective agents? The numbers and the rates of anti-infective agents that were prescribed to ADHD subjects were significantly higher compared to controls. Subjects with ADHD also required significantly more antibiotics from the 2nd and 3rd line therapies, which means that they needed more stronger antibiotics that require IV, and these antibiotics are usually not given so quickly to children. It may mean it could be a possible indicator of the higher severity of the infections in ADHD, in children with ADHD. If you remember what I said before about COVID and about the treatment that helps to lessen the severity of the disease, well, here these are children who are not treated, and we can see that there is an indication that the severity, not only the rate, but also the severity of the infections may be more, may be stronger. So these are the anti-infective agents in the table. You can see that the three strong antibiotics, all of them were given significantly more to children with ADHD as all the others. What about physicians' visits? The numbers and rates of physicians' visits were significantly higher for children with ADHD. Referrals to primary care physicians like pediatricians, family physicians, and GPs were all highly significant, more frequent. And also to specialists. We took two kinds of specialists, two types of specialists, because these are the two specialists that children are that are more common among children. That the children visit them more than others, which are the ENT specialists and the dermatologists. And in both of them, we saw that there is a highly statistical difference. And these findings highlight the burden of ADHD on the health system, because these children go more to physicians. They visit more physicians, they come more, they have more burden. Again, it is a table that shows it again and again. You can see big numbers, huge, there is quite an impressive OR, and the p-value is very small. What do we have here? We saw that pediatric ADHD is associated with significantly higher rates of all types of pediatrics infectious diseases, use of all kinds of anti-infective agents, including the stronger ones, and higher rates of primary care physicians and specialists. These findings support the hypothesis that ADHD is an essential risk for infectivity in pediatric populations. It is in line with the association between mental disorders and somatic conditions, and the associations between ADHD and bodily conditions. Thus, it is worthy of clinical and public health attention. But still, the association between ADHD and infection is unclear. We don't really understand why does it happen. So we tried to give several explanations. It was not easy. And what we could see, or what we could think about, were several explanations. Sorry, jumped. First one, it's the most common one. It's something that everybody instinctively says: hyperactivity and impulsivity. These children are hyperactive and impulsive, so there is an increased person-to-person contact and poor hygiene driven by ADHD-associated behavioral problems. Actually, it is a bit of blaming the victim, because you say it's their own problem because of their characteristics. But we are not so sure that this is the only explanation. Another explanation is an unbalanced autonomic nervous system activity. We know that children with ADHD, people with ADHD, have an unbalanced autonomic nervous system activity. It is suggested many times. And for example, urinary frequency, pressure, urgency, overactive or underactive bladder syndromes, dysfunctional voiding, and primary bladder neck dysfunction are all reported in children with ADHD. All of these are good reasons or good explanations to have more episodes of UTI. They all increase the risk of having UTI. Another explanation, which is more and more common now, and we talk about it more and more, is immunological vulnerability. A recent study from the Swedish National Registry showed a significant association between individuals with ADHD and the 13 most common autoimmune disorders. Likewise, Nielsen and al. Reported an association between maternal autoimmune diseases and an increased rate of ADHD among their children. So again, maternal autoimmune diseases and ADHD among children. Han et al. Found associations between maternal inflammatory diseases and neurodevelopmental disorders, specifically ADHD. Last explanation is the continuation of the previous one. Aberrant immunological mechanisms in ADHD individuals, including elevated levels of immunoglobulins like IgM, IgG, and IgA, alpha amylase, and the blunted cortisol level. A specific vulnerability in children with ADHD to particular infections, some of which support the hypothesis of increased immunological susceptibility in ADHD patients. For example, we know, even from before COVID, there were several studies about higher cytokine levels in ADHD individuals, specifically interleukin-3, interleukin-6, and alpha-TNF. Thus, an aberrant immunological response could be another possible mechanism involved in the higher vulnerability of ADHD subjects to infection by microorganisms. The study had several limitations. Despite its population-based character and large sample size, we have some unrecognized biases that could have influenced our results. The data were collected from a single HMO in a single country. It may not generalize to other countries' healthcare systems. More than that, the sample was largely Caucasians, because in Israel, most of us actually are Caucasians. Thus, it may not generalize to other ethnic groups. Conclusion: children with ADHD exhibit increased vulnerability to infectious diseases. Considering the high prevalence and chronicity of ADHD, these findings are a significant public health concern, especially during pandemics like the COVID-19. Therefore, special awareness of physicians is warranted, calling for further efforts to study this vulnerability and develop mitigating strategies to address it. Thank you.
Thank you, Iris, for a very interesting presentation. We now have some time for questions. Please type your questions into the Q&A box. Iris, I'm going to start off and ask, do we know if the ADHD children who had infections, does that exacerbate their ADHD? Is that something you've been able to look at yet?
Again, sorry?
Does it worsen the infection? And I'm sorry, among those children with ADHD who had infections, does the infection impact have a worsening factor on their ADHD?
This is a very good question, because we don't know the answer yet, of course, because we think it is a bidirectional mechanism. We know and we understand that children with ADHD have a more severe infections. For example, they need the stronger antibiotics, just as an example. On the other hand, there are some thoughts that there is some immunological, maybe not a deficiency, but a change, or some aberrant immunological mechanism that drives children to have a more severe ADHD, maybe to develop the genetic basis of ADHD to a full-blown picture of ADHD. But this is an assumption. We don't know enough about it. We know many things, or we think we know many things about parts of this puzzle. We think that we know that there are immunological deficiencies. We see it in other studies, but we don't know yet.
Always more to learn. Luis, do you have a question? I see your hand is up.
Yeah, thanks, Steve. First of all, Iris, I want to congratulate you for the presentation. I think Joe would be very proud if he had the opportunity to be with us. Why? Because as Steve mentioned, one of the key characteristics of Joe is to answer with data-driven data the clinical relevant research questions. And I think that what you are addressing here is very important and relevant clinically, and you are using a very nice data set for trying to answer the question. I think this is something that Joe did all his life using data to answer questions. So I think that this is a very important symposium. Thank you very much, Iris. I have two questions, Iris. The first one is, you mentioned several possibilities to explain the association found. And one of them related to the inflammatory syndrome. That is something that we are seeing a lot nowadays when we are discovering the connections of ADHD with medical conditions like obesity, hypertension, diabetes. Yeah, correct. You already answered the chance of being a child with hyperactive and more inattentive executive deficit symptoms, increasing the chance of the disorder. But I was thinking about also, as Steve was the one that showed us with lots of data, the genetic component of ADHD. If these children raised probably by parents with ADHD that probably are more less aware and take less precautions in terms of infections, if this not be one possibility to for this link. And the other question is a more methodological one, Iris. I would love to know if you had a chance to do any corrections for comorbidities. Why I'm asking this? Because whenever we look for the association between ADHD and accidents, for instance, it increased a lot, and one of the main drivers of the association is comorbidity. The same with mortality. So if you had a chance to adjust for psychiatric comorbidities, the data, thank you very much, Iris, for sharing this wonderful data with us.
Thank you very much. First of all, well, your first question is very, we thought a lot about it, about the parents, because as we said, many parents have also ADHD. And the truth to be said, our first assumption was that parents of children with ADHD many times neglect the child, and then they go to the physician when the infection is more severe. But as we could see, they go more to physicians and not less to physicians. They have more visits with physicians. So it seems that if at all, parents with or without ADHD of children with ADHD are more anxious and go to physicians more and no less. So this one is the contrary to what we ourselves thought. And we looked for it specifically for this reason. So because they didn't neglect the children in any way. The other question, well, we didn't have, as far as I remember, we looked for it, but you have to remember these are young children. Many of them did not have many psychiatric comorbidities. At least they are not written or not, it's a big data study. You have to rely on what there is on the files. On the files, there was there were very few psychiatric diagnoses. So it was quite negligible. The idea is that if at all, and these are things that we are looking for now, is not the psychiatric diagnosis, but the somatic diagnosis, because we find some very interesting things and very interesting associations between ADHD and some somatic disorders, and that are, how to say, to be continued in other webinars or other presentations.
Thank you, Edith. We have a question from the audience asking if it's possible to get a presentation after the webinar, get a copy of the presentation after the webinar. Sure.
It is already published, so there is no problem. It is published in JACAP, the journal, the Orange Journal,
yes.
And there is no problem to get. I always give my presentation.
Okay, so you can contact Professor Manor if you'd like a copy of the presentation.
And Steve,
or Ms. Wong, she has it.
Steve, let me remind all of us that everything will be recorded, so the people can have access to the presentation. Normally, nowadays, we have much more people looking for the presentations, not on live, but seeing later whenever they have time, because we have these time zone differences worldwide. So nowadays, we have much more people accessing the presentation. So everything will be recorded in the web side of the IACAPAP, so it's available there also.
Okay, fantastic. Another question, it is, this person says, thank you very much for the presentation. Have you found any relationships between ADHD diet and infections?
As far as I remember, we didn't look specifically for an association between the diet and the infections. We know that there are differences in people with ADHD and their patterns of diet. They used to eat a less healthy diet, but I don't know more than that about, I don't know about the relationship between, the association between that and infection. I have to say something very small about one of our assumptions for the future about the involvement of gut microbiota and ADHD, and a possible immunological mechanism that may involve gut microbiota and ADHD, because one of the immunological pathways is involving the gut microbiota. It's a vagal pathway.
Yes, no, that's one of the growing areas in ADHD research. The microbiome, I expect it will deliver a lot of important findings in the next decade. I will add, we do know that
maybe the problem is not what they eat, but what they get from what they eat.
Right,
and how
right. That's right. Because studies that have tried to manipulate diet to improve ADHD symptoms have not been positive when they're properly controlled. So we do know that although ADHD children may have poor diets, changing their diet does not impact their ADHD very much at all. Another question, would it be possible to say that that having ADHD itself will cause, by virtue of their behavior and restlessness, that they could contract more infections? I think you did mention this a little bit, but I think this person would like you to talk more about that ADHD itself makes them contract more infections.
Yeah, of course, because this is the obvious explanation. And I admit that I don't like this explanation so much, because for me, it's like blaming the victim. Because if you have more infections, it's your own blame because you were not behaving yourself. And we know that children who suffer from inattentive ADHD, like the inattentive presentation of ADHD, suffer from infections no less than the children with hyperactive ADHD. Well, it may be that the hyperactivity and also the inattention makes you more vulnerable to sickness, because you don't pay attention to instructions, you don't know how to keep your distance and things like that. But this may be only a very obvious explanation, and it can't explain everything, especially not things like UTI in boys. So I think we should try to look beyond the obvious. Otherwise, we will always stick to the obvious and look at ADHD as an behavioral disorder, while I'm more and more certain that it is not a behavioral disorder.
Well, Iris, that's another answer that reminds me of Joe Biederman, because Joe always looked beyond the obvious. He would always say, just because it's obvious doesn't mean it's right.
Right.
You know, one good example of the obvious, no, he was your mentor too, I know. It was, you know, another example of the obvious was not being correct, possibly, has to do with ADHD and obesity, which is relevant, of course, to inflammation. I thought for years that ADHD people would increase risk for obesity only because of impulsive eating and their symptoms of ADHD, but the genetic data are actually telling us that the genes that put people at risk for obesity have a causal effect on having ADHD. And so the story there is very, very complex. And I think it will be the same for infections as well.
Well, about obesity, it's even more complex, because you also have the dysregulation. One of the explanations was that they can't perceive satiety and when they are hungry. So then they don't eat well. They eat when they eat in a lot of, they eat a lot because they don't feel that they ate enough. And so this regulation is also part of it. But of course, yes, what you said is true. And it's even more interesting than that, because now there are studies that even when the mother is obese, the child has a high risk to suffer from ADHD.
Yes, yes. Very good. Okay, another question. Person says, just clarifying that all children with ADHD that were included in the study were adequately treated for their ADHD. Is that the case? Do we know that for sure?
Well, I specifically said that in this study, we didn't treat the children for ADHD. We did the study until the point that they were diagnosed. And the reason was that we didn't want to mingle the treatment with the results of naive children with ADHD. We looked for the 5 years before the diagnosis, when they were not treated, for sure. And maybe the next study should be about treatment and ADHD and infections.
I think so. Yeah, that would let us know whether perhaps it is some of the ADHD symptoms are related to the infection if they're well controlled. Let's see. I remind the audience, if you have questions, type them in the Q&A box. We have I should mention a few people just saying congratulations. It was a great talk, Iris. There's a lot of positive comments there. Another question is there a difference in the risk for infection depending upon the different subtypes of ADHD?
Unfortunately, because it's a database study, we couldn't have it. We have what we have in the files, and we don't have all the details we would like to have. to know the answer to this one, we need to do a prospective study and to have a control on the data, which we didn't have in this study.
I think we should also remind the audience that the subtypes of ADHD have been dropped from the DSM-5 and are now considered presentations because we now know that these the inattentive and hyperactive impulsive presentations change over time, and they're not what we consider persistent biological subtypes of the disorder.
As Luis presented so beautifully several times, that ADHD can come and go, or to be presented and not presented during the years. So adult ADHD and childhood ADHD are not so clear-cut as we thought they were.
That's right. That's right. Perhaps, Iris, you could tell us what do you think are the implications for practicing clinicians from your results?
Well, I think the first thing, and we began with it during COVID, because, you know, the sad thing is that even before COVID, there were studies about the association between ADHD and infections, and between the treatment to ADHD and less infections. And it didn't get any attention. And this is very sad, because when COVID began, nobody thought about it. The children with ADHD should continue with the medication, because medications are for school only or for studies only. And nobody thought about other aspects of the risk of ADHD. So the first thing is that clinicians should know that ADHD is a risk factor for many things. And it's not only relevant for studies. And the second thing is that if clinicians will know something about it, they will know how to tell parents. For example, I was telling parents all during COVID that a child must be treated when he gets out of home, because he is in a bigger risk. He has a bigger risk. So it is very important for clinicians, first of all, to be aware of this fact, and then maybe to teach parents how to behave according to it, because physicians don't think about it.
That's right. Luis, do you have a comment for us?
Yes, we are approaching the end of our time, and remembering Joe, that is always one step ahead of us in terms of the research. Iris, what are the next steps that you are thinking about? This is a very nice data set. You are able to show a lot of provocative data and very interesting and clinical relevant. What your group in Israel are thinking the next steps, taking in consideration the data that you presented us?
Well, there are several steps. I think at least one of them is very well known to Steve. It's about fever and ADHD, fever in young children and ADHD. We looked for fever in children who are less than 4 years old, and the possibility of being diagnosed with ADHD afterwards, because usually children are not diagnosed with ADHD before the age of 4. We also have another interesting study, another interesting paper, I think Steve got it too, about a possible association between ADHD and familial Mediterranean fever, which is a genetic disorder, but it is also an inflammatory disorder, which is quite common in Israel because it is common to the Mediterranean. And it reminds us the studies from the Northern Europe about lupus and the juvenile rheumatoid arthritis, that they also show that there is some association between ADHD and these inflammations, genetic inflammations. I don't know how to define them. So these are the main courses that we think about. We think more and more about how to better understand this relationship, these associations between ADHD and the inflammatory and the autoimmune mechanisms.
Very good. Well, I think we're out of questions now. Any more questions from the audience? Any last questions that Iris, any last thoughts you'd like to leave the audience with about your work?
Well, not about my work. I must say again that I love Joe very much. I think he's a huge loss, like a big black hole in the middle of the universe. and I would give everything that he would be here.
He was a huge loss to us. Many of the people here are too young to remember that, back in the 1990s, early 1990s, people didn't think that ADHD was comorbid with anything besides learning disabilities and conduct disorder and oppositional disorder. And Joe started publishing papers about ADHD and depression, and he was strongly criticized. I mean, he had people in meetings telling him he was wrong, that there was something wrong with the water in Boston was making these kids depressed or some crazy things like that. He persisted, he did his research, he showed that they were wrong. And now we know from the big genetic studies that not only are these disorders associated, but all of the disorders Joe said was comorbid with ADHD are genetically linked to ADHD by these very huge studies, which are incontrovertible. So his spirit of going into the unknown and persisting in the face of criticism is it's something I just have never seen before. And we may never see again, at least not in my lifetime.
I think his will to us is to be skeptical about everything, to ask questions, never to take things as they are, as they look like, not the obvious explanations, but always to look beyond the obvious.
Yes. And also to use your clinical experience to drive questions that you ask, and not to assume that you're doing everything right, that, I was trained at this very good medical school or a very good psychology school, I know what I'm doing, we're doing everything top notch. And he was at Harvard, Mass General, and he always thought he could do things better. I mean, he kind of almost, I would say, in a way, ran on fear that he wasn't doing enough for his patients. How could he improve things? And so much of the research that we did came from him coming back from the clinic saying, I don't understand this. We need to figure this out. The whole issue about pediatric bipolar disorder just stemmed from, literally, he one day said, we're seeing a lot of manic symptoms in our research studies of these kids, but we're not treating this in the clinic. So something's wrong somewhere. And he went on and launched a whole program in pediatric bipolar disorder that improved the lives of many children. I mean, it's really amazing the kinds of things that he did that were just totally out of the box. And he took a lot of criticism for it, but he persisted. He persisted through adversity. Yeah.
Well, thank you both for this wonderful presentation and discussion. I will share my screen again just to give the final announcements of our webinar. Thank you very much, Iris, and thank you very much, Steve, for being with us today. And as I mentioned it before, this presentation will, as usual, is recorded, so you can share and you can see later if you want again. So let me share my screen for the final announcements. And sorry, here we finished the question and answers. As Sue already mentioned it, an e-certificate of participation will be provided to those IACAPAP members who have attended the webinar and completed the survey at the end of the webinar. I want to remind you that our next online IACAPAP Lunch and Learn webinar will be in September. The topic is 25 years of childless mental health, disaster interventions, model of care, and potential lessons for pandemics and children experiencing military conflicts. The talk will be given by Professor Brett McDermott. And also, I'd like to remind all of you about our World Congress of Child-Adolescent Psychiatry and Allied Disciplines, the IACAPAP 2024 Congress, that will be held in Rio de Janeiro, Brazil. And the main topic is child development, mental health challenges, and the future of nations. The registrations are already open, and you can visit the IACAPAP site that you have here for registrations. And if you want to join IACAPAP, you are very welcome, and you can find all the information in the links presented here. So with this, I want to thank you very much all for being with us, and thank again Iris and Steve for this very nice presentation and discussion about this very relevant topic. I think that Joe would be very proud of all of us, and we certainly this is just a small tribute for everything that he done in terms of the development of child-lesson mental health worldwide, especially in the area of child-lesson psychopharmacology and ADHD throughout the development. Thank you all and have a very nice day. Bye-bye.
Thank you.